So welcome to GRIP Medical Grand Rounds. I think we're going to have a really interesting, different kind of grand rounds today, but I had a chance to meet and talk with Jay Kaufman in the previous hour, and personally I just find the kind of work he's doing really interesting and exciting. Gail Henderson, who was, we owe gratitude to helping Jay be here for Grand Rounds today, has worked with him for years, I think. And Gail's going to give his more formal introduction. So now, yes, immediately, no. Sarah told Gail she didn't have too long to talk, so she's going to give us a brief introduction.
Yeah, hi. So I'm really glad to introduce Jay Kaufman today. I am going to be real brief. Jay actually is from UNC and just moved to McGill. So he's currently out of town, but he's actually a long-term colleague and friend in the Department of Epidemiology here at UNC. He is a social epidemiologist, and he studies the ways in which health status varies by race, class, and other socioeconomic quantities. And today he's going to talk about his research, which is on race-specific pharmaceutical treatments. He is also a real talented methodologist, and some of the things that he's worked on are looking methodologically at how you use social factors as covariates for health outcomes. Jay is sort of astonishingly well published. Like, you know, you learn a lot about a friend when you try and introduce them and you ask them for their bio sketch. Jay has published well over 60 articles in really major journals, including Hypertension, The Lancet, the Journal Epidemiology, Annals of Epidemiology, New England Journal of Medicine, International Journal of Epidemiology, American Journal of Public Health, Pediatrics, Social Science and Medicine, and the journal Science. And I'm not going to take up any more time introducing him because I think that the topic for today's lecture needs as much time as we can give him before, as I've been warned, everybody rushes out. Okay, thanks a lot.
Thank you. Thanks. Is the microphone on? Yeah, thanks for that embarrassingly generous introduction. I did just move to Montreal in January, the best month to arrive in Montreal. When they offered me the job back about a year ago, it looked like Canada was a great place to go to. They were rolling in petrodollars and dumping it all into the universities because they weren't invading any other countries, so they didn't have anything else to do with the money. And it looked like a great opportunity, and it looked like McCain was going to win, and he was promising 100 more years of war in Iraq, and so it looked like a great time to jump ship. But then things changed, and in fact, the election outcome didn't go as I had expected, and already Obama has distinguished himself from all the other previous presidents and Canadian. Oh, it says number of pirates killed by each president. And goes through and shows that he's way ahead of our own Prime Minister, Stephen Harper, in this regard. And then all that, the oil money kind of dried up. It was $140 a barrel when I took the job, and now it's about $40 a barrel. And so they're not quite feeling like they're rolling in money anymore, dumping it into the universities. I negotiated my salary when the dollar was 1-to-1. So I said, oh, well, I'm making this at UNC, so just pay me the same thing. But then the Canadian dollar crashed in October. So now it takes $1.30 Canadian to buy a US dollar. Then there was the cold snap of January 14th to 18th when the temperatures in Montreal stayed between -15 and -25. And I got my $600 electric bill for heating that month. And then I found out that really missed the opportunity to be on Franklin Street last week, and that after a couple months in Montreal, people were asking me why I still wasn't able to speak. I said, I'm learning French, I'm getting better, and they've like, you've been here 4 months, how come you still can't talk? So all that's to say, I'm really happy to be back in North Carolina. We're at springtime right now. The flowers are blooming. It's warm. People are really nice. And I'm really nostalgic for UNC and all the people I left behind here. What I wanted to talk about today was the broad question of when we use ethnicity in medical decision making, and I'll pick a specific example today, which is ACE inhibition for treatment of hypertension. I wrote heart failure here, but I'm really going to focus on hypertension. There's a long tradition in medicine of classifying patients by race, and some defenders of this practice. This is a New York Times Magazine article by psychiatrist Sally Satel, saying it's a good thing to classify patients by race because different patients or different racial backgrounds require different care. And she specifically mentioned the example of ACE inhibition, saying that a study showing that ACE inhibition was ineffective for heart failure in blacks was useful research, and this showed physicians that they should make these distinctions. ACE inhibition goes back a long way. We have about 30 years of experience with this antihypertensive medication. Just going through the guidelines for different professional societies, the JNC7 guidelines about initial treatment for hypertension indicate that the first-line drug should be a diuretic, and then an ACE inhibitor, a calcium channel blocker, or beta blocker as an alternative medication. The Canadian guidelines pretty much agree. Also, initial therapy should be monotherapy with a thiazide diuretic. But the American guidelines, JNC7 guidelines, do point out this well-known observation that African Americans seem to have a blunted response to ACE inhibition. The odd man out here, interestingly, was the British guidelines. These are the guidelines proposed by the British Hypertension Society, which actually segregate patients into two groups, young and non-black, compared to older and black. And if you're young and non-black, you're supposed to start out on an ACE inhibitor. If you're older and black, you're supposed to start out on a diuretic or a calcium channel blocker. They don't define who's black and how black you have to be and things like that. It's kind of an odd category in medicine because there's not really a good definition. It's a social variable, so it's not really well defined. Interestingly, in the United States, we have a Directive 15 by the Office of Management and Budget, which defines exactly who's black and who's white. And the interesting thing about those guidelines is that, number one, they explicitly say that it's a social categorization that has no scientific background or no scientific justification. And the second interesting thing about that OMB guideline is that it defines black as being descended from one of the black groups of sub-Saharan Africa. So it uses the word in the definition, so it obviously is not really a definition at all. The British guidelines have as a justification for this dichotomy between black and non-black the idea that blacks are a low renin population, and that's why ACE inhibition is not going to be effective for them. An interesting observation about that justification is that when you look at the citations for that work showing this difference in average plasma renin, it says that if you knew the plasma renin measurement for individuals, that would not be a particularly useful guide for antihypertensive therapy. So it seems that race is being used here as a surrogate for a variable which, if you knew the value of that variable, wouldn't actually be terribly useful clinically. Nonetheless, it's pretty strong consensus in the literature that this blunted response for African Americans exists. So if you go through about any of the hypertension textbooks, they all make reference to this well-known consensus. ACE inhibition less effective for blacks unless combined with a diuretic. Blacks respond less well to monotherapy with renin-suppressing drugs. African Americans exhibit less fall in BP with ACE inhibitors and beta blockers compared to calcium channel blockers and diuretics. Monotherapy with ACE inhibitors less effective for blacks unless a diuretic is added. ACE inhibitor less effective in blacks. African Americans resistant to ACE inhibitors. This difference is attributed to a sodium overloaded state. So you get slightly different language, but this general consensus appears, as I say, in just about every hypertension textbook I found. Norman Kaplan's is a particularly well-known book now in its 9th edition. Again, blacks respond less well to monotherapy with renin-suppressing drugs, but these should not be denied if indicated with addition of a diuretic. It's also true for reviews of journal articles. This one, Management of Hypertensive Disease in Black Patients, indicates same thing. Diuretic calcium channel blockers suitable as first-line agents for blacks, whilst, you can tell it's British authors because they say whilst. Beta blockers and ACE inhibitors tend to be less effective due to the low renin state of these patients. This is a review by Janice Douglas that appeared in Archives of Internal Medicine a couple years ago, Again, following the JNC7 guidelines, that ACE inhibitors are probably not the first line therapy for anybody anyway, but mentioning this, some evidence of less blood pressure response for African Americans versus white patients. And we have for some medications actually differential dosage guidelines as well. This is the package insert for Trendolapril, marketed as Mavic, which says that you should get 1 milligram per day if you're non-black and 2 milligrams per day if you're black. There's no citation in the package insert, but there's a bunch of studies from the 90s showing that blacks achieved a similar response to whites in terms of blood pressure reduction if the dosage was increased. This is not for treatment of hypertension, but this example of race-specific pharmaceutical marketing reached its extreme in the example of Bidil for heart failure, which was a combination of 2 generic drugs, which was marketed just for African Americans on the basis of a clinical trial that enrolled only African Americans. The therapy was successful, and they said, so this is a drug for African Americans. The company actually stopped marketing the drug, but not because the paradigm wasn't working for them. They really overpriced it. Because it was a generic drug, or a combination of 2 generic drugs, most physicians were prescribing the 2 generics instead of the highly priced combination pill, and insurers refused to pay for it because it was expensive. And so it's a sort of a complicated business story as to why they went out of business, but the paradigm still exists. The idea that the FDA in 2005 would approve a drug just for one racial ethnic group. The FDA also used this example of ACE inhibition to argue that clinical trials should be identified by race, the patient should be identified by race, because of this possibility of race-specific efficacy. So they specifically mentioned in their new guidelines for clinical trials this example. Black people additionally have poorer response than white people to beta blockers and angiotensin-converting enzyme inhibitors as a sort of paradigmatic example of why you would want to have racial information when looking at efficacy or effectiveness data for drugs. So, summary of current consensus. Diuretics are the preferred initial monotherapy for everybody, including African Americans, and they work just as well in all populations. Calcium channel blockers are equally effective in blacks and whites if a second drug is required. Blacks respond less well to ACE inhibition and to beta blockers as monotherapy, but in combination with diuretics have equivalent response. So then I would ask 2 questions about this general consensus. First, I want to raise a couple of points about the evidence base for that, but then spend more time on the question of what would we do with this clinically. If we accepted this consensus as true, then what would be the clinical implications of that? So just a few comments on the evidence. It seems to me that there are a number of examples where there seems to be a prevailing opinion, and the evidence is described or marshaled in a way that is made to be consistent with that opinion in a way that sometimes seems a bit convoluted. So I'll give an example here for this review by Lizzie Brewster, and this was also a Cochrane collaboration review, indicating that looking at antihypertensive treatment for African Americans, that ACE inhibition doesn't differ from placebo in several different outcomes here. The authors here used blood pressure reduction, both systolic and diastolic, and also attainment of treatment goal. So the abstract simply says that ACE inhibition wasn't different from placebo, but that the other major classes were. There's several things about the way this was conducted, though. If you look, you see that all black populations are combined into one group. Now, whether you think of race or continental ancestry as largely a social variable or conveying some information about genetic predisposition, you still wouldn't consider black populations from all over the world as having anything in common in either respect. So lumping everybody together is a little bit suspect. The second thing is that there are actually a number of different outcomes I mentioned here. You have significant change in diastolic and systolic blood pressure with ACE inhibition. And for the outcome of achieving treatment goal, that's where you have a meta-analysis of 3 studies that shows no significant difference. But 2 of those studies are per protocol analysis as opposed to intent to treat analysis. And if you look at the intent to treat analysis alone, then you get a significant response or a significant difference. So I only bring this up to say that in order to put the non-significant result in the abstract, you really had to sift through the evidence very carefully to pull out the one thing that was non-significant out of all the different tests that were conducted. So it's a little bit selective. The next example is a large trial that was done, the ALLHAT study that was done for over 30,000 patients in the United States and Canada, which provides most of what we know now about the relative efficacy of diuretics, calcium channel blockers, and ACE inhibition for lowering blood pressure. It involved a third of the patients being black, so it's a big sample of black patients. They all had to be American or Canadian, over 55 years of age. They had to have a baseline blood pressure of just above 140/90, but less than 180/110, and have at least one additional CVD risk factor, and there was no washout period required in the ALLHAT trial. So in a large randomized trial like this, where the treatment takes place in physician offices, 623 different clinical sites throughout the United States and Canada, obviously you have variation in treatment after randomization. So you had a large number of patients who stopped taking their assigned study drug. So by the first year, you're already down to about 80% of people no longer on their assigned drug, alone or in any combination. And by 5 years for ACE inhibition, you're down to 30% of the people no longer on the drug. And you have 5 to 10% of the patients making a complete switch over to one of the other arms of the trial. So you have this differential noncompliance with treatment in a way that could be informative, because you have people being treated by their individual physicians who have some ideas about what's appropriate therapy. The patients are obviously not blinded, or the physicians are not blinded to the racial identity of the patients, and the patients have other characteristics that lead them to move on or off a drug. So the comparison is obviously compromised by the fact that people are no longer on their randomized treatment. Nonetheless, overall, in the ALLHAT results, you have a lesser response for ACE inhibition compared to the other drugs for all groups, but especially for African Americans. Now, another thing about this comparison is that the comparison of the randomized groups, say within the black or within the white population, every characteristic of those groups is balanced across the different treatment arms because of randomization. But that would not be true for blacks and whites. People aren't assigned randomly to be black or white, so those groups are not balanced, right? Just flipping to this slide, you see that the prevalence of a number of different comorbidities is widely different for blacks and whites, right? Blacks have about 15% higher prevalence of diabetes, about half as much a history of coronary heart disease, a third the prevalence of history of coronary revascularization, twice as much left ventricular hypertrophy. So these patients are not in any way comparable in terms of these other characteristics, and so there are a lot of other reasons to imagine why you'd see a difference between the populations of treatment response. The other thing that I skipped over here, I read the slides out of order, is that you had difference in visit adherence, a dropout in the study as well. So for non-blacks, about 93% of expected follow-up visits were completed in the three treatment groups, and a little bit lower for blacks, 89 to 91%, and a little bit lower for ACE inhibition. So the other thing about this is that in a randomized trial, you have this balance of all covariates across the two groups because of randomization, but you don't have balance across groups like black and whites that are not randomized. So you can look at the treatment within group and get an unbiased comparison. You can't look at the treatment across groups. So, summary of the ALLHAT results. The mean follow-up blood pressure, systolic blood pressure, was 2 millimeters higher for ACE inhibition compared to the diuretic group, and this led to the general conclusion for the study that diuretics were still supported as the first-line antihypertensive. There were 4 millimeters, systolic blood pressure was 4 millimeters higher for blacks, and 3 millimeters higher in those older, over 65 years of age. And ACE inhibition modestly less effective than for blacks than for non-blacks compared to the diuretic and the calcium channel blocker groups. But randomization, as I said, doesn't apply to the comparison between blacks and non-blacks. So whenever you have a difference in baseline characteristics like that, you will in general get effect modification. right? This is, it's a statistical artifact that as the baseline risk changes, then the effect measure is not going to be constant on some scale. If, for example, if the risk difference were constant across different baseline risks, then the risk ratio wouldn't be constant. If the risk ratio were constant across different baseline risks, and the risk difference couldn't be constant. So you have to get effect measure modification. You have to get heterogeneity of effect on some scale when the baseline risks are different, as they are in, for example, with blacks and whites. So you would not expect in a randomized trial of different patient populations that you would have the same treatment efficacy in the two groups. Clinicians had control over dosage and altering of the regimen and were not, of course, blinded to the patient race. Large portions of patients in all groups didn't adhere to regimen, and so potential exists for severe selection bias, and there was no washout period. So these are all just things to be hesitant about when thinking about studies of this kind that give us most of the evidence that we have about treatment efficacy for antihypertensives. So the next question then, after raising a couple of cautious concerns about the level of evidence, the quality of evidence that we have, is to consider what the clinical ramifications would be of such a difference if we take it to be true. Consensus appears to be that there's a slightly blunted blood pressure response for African American black hypertensives compared to non-black hypertensives when given monotherapy in equal doses to ACE inhibitors for whatever reason. You can hypothesize any cause of that difference, whether it's different comorbidities or baseline characteristics, whether it's some genetic predisposition, some social factor that differs. It doesn't matter for what reason you might suspect that, but if we accept this consensus that there's this slightly blunted response, what would be the rational clinical implication of that? There was an article in 2004, I guess this is, by Ash Segal in Hypertension, I think it's 2004, making a schematic representation of the fact that if you see a significant difference between two groups, you can still have tremendous overlap between the individual patients within those two groups. So you might see a mean racial difference in the effect of a therapy, like an antihypertensive, but most patients would fall directly under both curves. And so what's a significant difference for the population mean might not be very interesting or useful when you're making a prediction for an individual. And in his article, he calculated the percent overlap between those distributions and said for ACE inhibitors, which I've circled in red here, that percent overlap is about 90%, saying that for 90% of patients, they could fall under either population, under either of the curves. So we thought that we would try to do that a little bit more formally instead of just arguing about that heuristically. Is there a way that we could calculate that difference a little bit more formally? So we did a PubMed search for all articles involving blacks and whites on ACE-Inhibition therapy, restricted to English language, published since 1990, and these were collected by Toon Nguyen and meta-analyzed. We found 222 articles that met these criteria, but we restricted studies that were not randomized if they involved children, if they didn't have data on the blood pressure change and its standard deviation, if they were not monotherapy. And so we ended up with 12 articles that met the inclusion criteria that led to 19 different groups. And when we meta-analyze those 19 different groups, we get a pretty homogeneous response across those 19 studies, which shows treatment differential for blacks and whites, or blacks and non-blacks, of about 4 millimeters of mercury systolic and about 2.5 millimeters diastolic. So the literature conforms to this general consensus that there's a modest treatment differential between blacks and whites. But the other thing that we observe is that that difference is very small compared to the within-group variability. So whites had an average response of about 10.5 millimeters of mercury, blacks about 6.8, and that gives this 4.5 millimeter difference between blacks and whites for systolic. But the standard deviation for whites is 12, and the standard deviation for blacks is 14.5. So that difference between populations is very small compared to the difference between the variability within each population. So to make a picture of that result from the meta-analysis, you see that the results are actually much more overlapping than the schematic representation that was suggested by Segal. So in fact, the black population is a little bit more spread out and a little bit shifted to the left compared to the white population, and this is for systolic and this is for diastolic. So It's actually a little bit less impressive even than what we might have suspected based on the previous diagram. If we wanted to ask a question like, what's the percentage of white patients who would have at least a 10 millimeter decline, all we have to do is take the point of 10 millimeters on that distribution and add up all the probability to the right. So when we add up all that probability, we get about 52%. And if we did the same thing for the black distribution, we'd get about 41%. So there's a relative probability of success. If we define success as a 10 millimeter change, you get a relative probability of success of about 1.27. Most patients, of course, fall in the middle of these distributions, right? So a lot of that, a lot of the play there is in the tails of the distribution where the difference is much greater in relative terms. And most patients fall in the middle of the distribution where you wouldn't, where knowing that a patient was black or white wouldn't give you very much information about the probability of falling in any particular place. Picking 10 millimeters is a kind of an arbitrary place, so we can consider that same cumulative distribution from any point in the distribution to the right tail and adding it up for every single blood pressure target we might consider. So I've indicated the 10 millimeter with a dot here, but I made the same computation for every single possible goal change in blood pressure. And it turns out that you don't get much better than that 1.27. You get up to a maximum of about 1.35 when you're looking at something over a 20 millimeter decline, but the relative success for whites over blacks in reaching the goal never gets above about something between 1.3 and 1.4. And that's a cumulative. It's from the right, from the point of the treatment target to the right, all the way to positive infinity. You could also do it by comparing the height of those two distributions. And so this considers the relative success at every point, not cumulatively. And again, you see that it never gets better than about 1.3. So that's the relative advantage for whites based on these data. So then, what would you do with a relative success probability of 1.3? How would you apply that clinically? Again, something that's significant at the population level is not necessarily significant for making a judgment on an individual. How would we make clinical decisions? I'm not a clinician, but people tell me that the way clinicians make decisions is something along the following. Will a drug work in this patient? You start with a prior probability. It turns out that we have a big problem in epidemiology trying to shift people to a Bayesian way of thinking, but apparently in clinical medicine, everybody's already a Bayesian, because you start out with a prior probability, which is some average for the entire population before you've observed something specifically about the patient, the percent of time that the drug works in general, say, and then you apply your observed information. The patient appears to be white. That's some diagnostic test that you're conducting, and that allows you to obtain a posterior probability distribution by integrating that observed information, where here we're defining the drug working, meaning you obtained the desired blood pressure change. So the idea here is you're starting out at some particular place, and you observe something that shifts you to some higher degree of certainty that the drug is going to work. And the idea is to move close enough to this 100% that you're sure you want to use the drug, or close enough to 0 that you're sure you don't want to use the drug. So if you're stuck somewhere in the middle, you need to make additional observations about the patient, or additional tests, in order to make the decision. So the algebraic machinery is just to start out with that prior odds, multiply it by the likelihood ratio for a given test, and that gives you the posterior odds. So you might need to convert from probability to odds in order to make that calculation. And again, the goal is to get out of this middle range of uncertainty and move to treating somebody or observing somebody. This is the kind of logic that's employed in clinical epidemiology and clinical medicine textbooks like the SOX textbook and the Sackett textbook and things like that. Ideally, you'd like some kind of observation that would distinguish populations between non-responders and responders, something that you could measure that would separate those so that there wouldn't be much overlap. There's not too many of the non-responders that are above this line, and not too many of the responders that are below that line. So for most people, you're going to make the right decision. Unfortunately, in our example, there's no place where we can put that line where we would be able to distinguish between those populations very effectively. There's a large literature on exactly this problem. So it's not like I've discovered something new or we're talking about something new when we say that something that has a relatively modest association in an epidemiologic study cannot be used as a clinical decision factor. You can't use it as a way of making a decision about an individual patient. So just taking a little bit of the algebra from the Pepe article shown below, she expresses it in terms of odds ratio instead of likelihood ratio. But she says, so suppose you had something that had a big association in terms of an epidemiologic study. Like over in epidemiology, we get pretty excited if we find an odds ratio of 3. She says, suppose that a marker such as white race misclassifies 10% of non-responders as responders, and that the odds ratio is 3, which, again, in our journals, we would consider to be big news. She said, this test must therefore identify only 25% of the true responders. That is, 75% of the true responders are not going to be treated. Alternatively, if you had a marker of treatment susceptibility, such as white race, with an odds ratio of 3 that could correctly classify 80% of the true responders, then it must mislabel almost 60% of the non-responders as also being responders. So clearly this marker is not going to be clinically useful in any way. You'd really need to be up in this range of an odds ratio of 30, 40, 50 to be able to make a clinical decision that was not going to misclassify most of the people. So just taking the example of the odds ratio that I computed before, 52% of whites reaching the 10 millimeter treatment goal versus 40% of blacks, and converting that into an odds ratio. I expressed it as a relative probability before, and we know that an odds ratio has to be further from the null than the relative risk. So we had a relative risk of about 1.27, I think it was. If you express this as an odds ratio, you get 1.6. So you see this is half the size of the Pepe's example of 3, which was clinically useless. And so with our 1.6, we see that if we had 100 patients who were black and 100 patients who were white, and we applied this as a treatment guideline or a strategy for making a decision about the individual treatment, that we'd be making the wrong decision for about 45% of the patients. So we're not doing much better than flipping a coin by using that as a treatment guideline. Right? A large number of white and black patients are getting the wrong drug because they're on the wrong side of that division line. So how to synthesize some of these issues. Strong consensus that black Americans have less of a blood pressure change with ACE inhibitors as monotherapy than with diuretics or calcium channel blockers. No clear explanation, little information on other groups, and not clear how this interacts with other conditions such as diabetes, obesity, heart failure, et cetera. But nearly all guidelines mention this without recommending it as a basis for differential treatment, but some, like the British guidelines, actually use it as a way of differentiating patients. Strength of the evidence is questionable because of weaknesses in studies and meta-analyses. No random assignment of race, obviously, is possible. Frequently no washout period, so it's confounded by previous treatment. Imbalance in covariates between these two groups of blacks and whites. The fact that race is not blinded, right? That physicians are treating patients and they're aware of these, of this consensus, and they might make decisions in accordance with that. Differential noncompliance between the two groups, possible. Some bias in interpretation. I suggested some of the studies bent over backwards to be consistent with this general idea, even when they had other data that might have contradicted it. And the absence of clear definitions about who's black and who's white, who should be in these categories. Even if the observed blood pressure response distribution were taken at face value, if we say that this maybe 4 millimeter mercury systolic blood pressure difference is real, we accept this evidence, it's probably too small to be relevant for any clinical decision that might involve individual patients. It could perhaps sway a decision at the margin, but evidence suggests that physicians attribute much more weight to this distinction than it deserves, which denies useful therapy potentially to many patients unnecessarily. Now you might say, if there's this slight advantage by knowing this information, like it was a little bit better than chance, why not make use of a small amount of information like that if there's no cost to it? Because when you look at a patient and you classify them according to their race, or what seems to be their socially recognized race, there's no cost to that diagnostic test, and it's not invasive. So if it's free, why not use free information? And the answer, I think, is that there is a cost to this that is the cost of people exaggerating that evidence or attributing to it a level of significance beyond its evidentiary basis. So I'll give a couple of anecdotal examples. This is a letter in American Journal of Cardiology. There was a previous study by Ilksoy that found that a hospital in Atlanta wasn't meeting treatment guidelines for heart failure, beta blocker therapy for heart failure. So this previous article simply said, well, we should manage patients according to guidelines, and we should have more patients in this hospital on beta blockers. So someone wrote to the American Journal of Cardiology and said, no, we don't need to treat these patients. That wouldn't be necessary. African Americans with hypertension have shown a blunted response to beta blockers. They seem far less compliant with beta blockers than diuretics due to the side effects of sexual impotence and weakness. Medicine is only good if the patient takes it as prescribed. So this letter writer, it's just a letter, but this person is saying, these patients don't take the drugs anyway because they're only interested in sexual function, and we don't have to meet treatment guidelines for these patients. So there's no citation here that indicates that this is really based on some evidence, but it's this person's opinion that this group has characteristics that would make it unnecessary to treat them according to guidelines. Here's another example from a physician named Garcia. What's his first name? Richard Garcia, I think. He talks about a childhood friend who wasn't diagnosed with cystic fibrosis until she was 8. Over the years, her doctors described her as a 2-year-old black female with fever and cough, 4-year-old black girl with another pneumonia. Had she been a white child or had no visible race at all, she would probably have gotten the correct diagnosis and treatment. Only when she was 8 did a radiologist who had never seen her face-to-face see her chest x-ray and ask, who's the kid with cystic fibrosis? So the implication here is that there is a prevalence difference in cystic fibrosis between blacks and whites, but it was overemphasized in the judgment of clinicians who looked at the patient and said, oh, black kids can't get CF, they must have some other condition. So it was an exaggeration of the true difference, and that's the cost, right? The cost is people using this impression, like all the textbooks that said black populations are resistant to ACE inhibition or ACE inhibition ineffective for black populations. It is very modest treatment difference between these two groups, and it's exaggerated into a categorical difference, like this drug doesn't work in this population, or this population doesn't take this drug anyway. And it's that kind of categorical thinking, that kind of exaggeration, that's the cost. So we have a large number of studies now that indicate that race enters into clinical decision making in ways that are irrational, and this is the cost of allowing it to be used in a way that might be rational, right? So we could say, well, there is this modest difference for ACE inhibitors. Should we use that? And unfortunately, the evidence from many studies is that people use the race information so irrationally that there's the danger of that exaggeration. So a number of studies, I'll mention, for example, this one by Loring and Powell. They created ambiguous psychiatric case presentations. I should say one case presentation. They created a description of a patient that was meant to be ambiguous, and they sent it to a psychiatrist, and they asked the psychiatrist to come up with a diagnosis, and they randomly assigned that case to be described as male or female or black or white. And the results came back in the predictable way. The white women were all depressed, and the black men were all schizophrenic. And in this design, you really could say that you had the unconfounded effect of race on that decision, because there were no patients, no real patients. So there's no imbalance of any covariates here. The effect of race there really is estimated unbiasedly by the randomized design, because there were no human beings involved in the study. I mean, the only human beings involved were the psychiatrists. So that's an unbiased estimate of the effect of race in making that decision. A more famous example of that is this article by Ken Schulman, who was at George Washington at the time, and now he's at Duke, where he created videotape case presentations of people complaining about chest pain. And he had the exact same script, and he had it read by 8 different actors, 2 of them black women, 2 of them white women, 2 of them black men, 2 of them white men, and had physicians decide that they should be referred for right heart catheterization. There was a difference in the recommendation, the referral, which was what they wrote the article about, but it's interesting to look at the table of characteristics, because the physicians also classified the patients according to many other characteristics, aside from whether they should be referred. And there were significant differences in hostility or friendliness, even though these patients were all reading the exact same script. The degree to which patients were dependent or independent, The black men were considered to be low socioeconomic status, even though they read exactly the same words. They were also judged to be more likely to miss appointments and less likely to comply with treatment. In fact, the white women were more likely to sue, according to the doctors. So this is an example of, again, of clinicians using race in a way that's not rational, but that compromises the treatment for an individual patient. So again, this is in the direction of trying to indicate what the costs are for teaching people to think about race when making clinical decisions. Providers may hold preconceptions about patients based on perceived racial, ethnic group identification. Many examples of stereotyping, like the letter from Jack that I showed in the Journal of the American College of Cardiology about stereotypes that physicians hold about patients, but there are many, including the idea that patients are less likely to comply with treatment, or interpreting the symptom of illness as a less reliable indicator of severity for a minority patient than for other patients. In fact, there's a nice series of studies by Knox Todd, an emergency room physician at Grady Memorial in Atlanta, looking at differential analgesic prescription for people coming to the emergency room with long bone fractures, right? So adjusting for every possible indicator of, a rational indicator of treatment, minorities get much less pain relief for bone fractures than whites for no apparent reason. And it can only be attributed to this idea that the symptoms of pain expressed by the patient are not weighed as heavily for minority patients as they are for white patients. And there's a series of, I mentioned these articles by Balsam McGuire, a series of econometric analyses showing the way that patients are systematically disadvantaged by these kinds of stereotypes. Even if the clinician is entirely well-intentioned, the existence of such stereotypes lead to less effective treatment for minority patients than for white patients. So, as an overall conclusion, the idea of a best treatment option for blacks and whites seems silly given substantial heterogeneity. Why in the package insert for Mavik do we have a different dose for blacks and for whites, but not a different dose for obese patients and non-obese patients, for diabetics and non-diabetics, for any of a number of different axes of clinically relevant characteristics? Instead, we pick this very strange, historically convoluted variable of race and say, this group needs a different dosage. It seems a very odd thing for our society in this age to be focused on race as the one variable that you're going to use in order to make a differential treatment assignment like that. The impulse to have race as the main informative distinction for medical care seems to derive from an earlier age that I think by the 21st century we should probably get beyond. Right? We still have traditions like saying, identifying patients by age, gender, and race that exist from an earlier time period, and it might be time to enter the 21st century. Thank you. So I was told to end at 10 of, so I'm looking at the clock, and it's exactly 10 of. So I guess, I don't know if you have questions. Yeah. Okay.
People will just raise their hands. So
great.
I have a question kind of related, kind of unrelated to what you talked about, related to our conversation earlier. I'm also interested in hearing, so you spoke to the use of ethnicity as whether it's a valuable marker or not. What about this whole issue of what ethnicity may or may not mean in terms of actual phenotypic or genetic differences that is what we're guessing, is what we're dealing with if we're picking a group from one part of the country or one part of the world or one ethnicity. And what I'm sort of in a vague way, not a vague way, a disorganized way alluding to is the whole issue of pharmacogenomics and whether it's going to be possible to weigh all these different polymorphisms and how those fit into our use of drugs.
Right.
As an ACE.
There's a lot we don't know, so it'd be premature to say anything very definitive, but I would say by now there's a lot that we do know about the relative magnitude of these things. So we know that for any given polymorphism that we may study, the effect is, for most outcomes that are complex diseases, cardiovascular disease and cancer and things like that, not single nucleotide polymorphisms that lead to something like cystic fibrosis. But for most complex diseases, the effect of a single polymorphism is pretty modest. So even if we measure the polymorphism directly, it's not clear that we get a lot of information for treatment based on that one variant. Then we also know that the effect of continental ancestry on the prevalence of these different polymorphisms is also very modest. Right? If we measure a large number of polymorphisms, we can sort people into continents pretty well. But for any given variant, the population prevalences in different human populations are pretty similar for almost all variants. There's a small number that vary dramatically by continent, and they tend to be things that are not, that as far as we know, don't have any functional role, which is why they vary heavily from continent to continent. They're allowed to vary widely because it seems that they don't do anything. So these are used now as these ancestry informative markers that can be used to classify people effectively as having ancestry from one continent to another. But when we look at things that actually have a functional purpose, they tend to be pretty conserved across populations because they have a functional purpose. So it's hard to find things that have a large prevalence difference. That means that continental ancestry is a very weak surrogate for prevalence of these polymorphisms. Polymorphisms are have a very weak effect on the outcome. The conjunction, the combining two weak surrogates is going to lead to almost no information there. So I think the prospects look pretty dim. Yes, sir.
Let me ask the corollary question because it's such a lovely lecture on small effectology. When you showed us the ALLHAT, you pointed out the randomization error in this thing called black-white differential. And because it was recorded in the ALLHAT, even though they didn't randomize by it, and you used the surrogate outcome as the object lesson, this trivial change in blood pressure. How small an effect should we believe when the randomization error is hidden, which we didn't measure it, and the outcome is important, say heart attack? Would you believe a 2% difference in heart attack over the course of 5 years if we randomize 6,000 men to one treatment or another? Is 2% likely to reflect randomization error or health effect? How small? When do we stop reading this junk? When does
the confusion there is over the idea of significance, because what we're identifying when we say something is significant is that it's not due to sampling variability. It's not because we happen to grab a group of patients that just happen to be different in some way from another group of patients. And this process of grabbing a sample from some target population and then making an inference about the target population from the sample is the thing that we're identifying with the p-value, right, to say it's significant, right? So we rule out that sampling variability with that small p-value, but we don't rule out a million other reasons why those patients are different, right? There are all kinds of other reasons why you'd get a different response. And so the technique that we use for declaring something significant doesn't really speak to most of the things that we care about. So what difference would I believe? This differential efficacy for ACE inhibition seems to be well replicated across studies, right? In a large number of studies on the meta-analysis. That's right. So exactly. So I believe that it's not sampling variability. So I believe that p-value is valid in the sense that it's not just a type 1 error. It's not just that I happened to grab a strange sample when I took that one study. But that doesn't tell me what it is, right? It is due to something, some unmeasured difference between these populations that, as you say, can be socioeconomic status, can be some behavior, could be some gene, could be some anything. But that difference doesn't tell me anything about what is actually going on. It just rules out that one minor alternative hypothesis of sampling variability, which is probably the least interesting and least important. There are all kinds of other study improprieties or sources of error, sources of bias that it doesn't speak to at all. So what difference how small a difference would I believe?
The example I gave, the 6,000 randomized men and a 2% difference in heart rate for 5 years. How likely is that to be reproducible? How likely is that to reflect some randomization or something we didn't measure?
Oh, well, something we didn't measure. I mean, I'm not sure I entirely understand the question. If the study were well conducted, I would believe that it really wasn't just because of sampling error. It wasn't a type 1 error. But that still wouldn't tell me anything about what it was. So every other hypothesis, every other explanation is something that's unmeasured. So I don't know what you mean when you say, do I believe it or do I not believe it?
We're asked to believe that kind of outcome. If it was a 40% difference in heart attack rate, it may still be fooling us, but I want to know about that. My patient deserves that. If it's a 1 in 1,000 difference in heart attack rate, I can't imagine that's going to be something that's going to sway my clinical decision-making as a basic doctor.
Yeah, I mean,
I'm looking for some advice from you since you're looking at this issue here of small effectology, of where I should start to work.
I think you should start to worry. I would worry about all those results in the sense that, you know, when you have randomly assigned groups and they differ in some significant way, then you say, okay, it's not due to sampling variability. It must be the thing that I assigned. It's the thing that I actually assigned to these people. If I randomly assign 2 groups, one to take the drug and one to take the placebo, and I see a significant difference, I know it's because of the drug. When I take 2 observed groups, like men and women, or blacks and whites, or tall people and short people, or anything that I didn't assign but is just observed, then there are an infinite number of ways that those groups can be different. And there's
example with the 6,000 men, some of them have bad heart disease, some of them don't. We don't know the difference because we haven't done the test.
Those 6,000 are dying off even as we talk about it. One important cause that you're saving is one damn thing we don't have to remember is this ACE inhibitor thing. And anything you can eliminate among the things you have to remember is the greatest cost saver.
Well, I just made a very thought-provoking presentation, which I immensely enjoyed. And I'd like to thank Jay, but also tell you that as the hour's ending, I know many people have to leave. If you have further questions, I think Jay has a few minutes.
sure.
Answer.
Thank you.